Welcome back. This is Ian Bodford.
And Liang Lu.
And this is the Clinical Correlation.
Today's case is...
This is a 35-year-old male from Myanmar with no significant past medical history who presents with a chronic cough. He also reports night sweats, fevers, and weight loss. His cough is productive of yellow sputum.
For the past several years, he has been living in refugee camps throughout Asia. He reports that he once had a positive tuberculin skin test, but at that time his sputum test was negative.
His vital signs are essentially unremarkable. On exam, he has mild supraclavicular lymphadenopathy, but his breath sounds are normal.
Chest X-ray is performed and read as a constellation of findings concerning for active TB infection.
Tuberculosis is caused by Mycobacterium tuberculosis. It is an obligate pathogenic bacteria that has a waxy coating on its cell surface due to mycolic acid. This makes it resistant to gram staining.
The Lowenstein-Jensen agar, also known as an acid fat stain, is used instead. The bacteria are highly aerobic, requiring a massive amount of oxygen for their growth. Thus, its affinity for the lungs of mammals.
There are different types of tuberculosis infection. The first is the primary infection. This term is used to describe a new tuberculosis infection or active disease in a host who was previously naive.
Primary infections are generally always asymptomatic and may only be diagnosed due to a positive PPD or quantiferin gold test. The infection is generally contained by the body in the form of tubercles. It can spread hematogeneously and has an affinity to areas of high oxygen content, like the apex of the lungs.
The body's immune system walls off the infection and prevents the spread of the disease. In immunocompromised patients, the primary phase may be rapidly progressive and fatal.
Speaking of PPD testing, this is also known as tuberculin skin test or a MAN2 tuberculin test. A small amount of TB antigen is injected under the skin. If someone has antibodies against TB, the antigen will be attacked, creating a reaction in the skin. The test is read 48 to 72 hours after injection.
The size of the induration matters depending on the patient's risk factors and exposure status to tuberculosis.
In a small percentage of patients after a period of latency, the host's immune system can no longer contain the infection. This leads to a reactivation tuberculosis.
Symptoms of reactivation disease include low-grade fever, malaise, weight loss, cough, and night sweats. Almost all will have some type of pulmonary involvement. Only around 15% will have extrapulmonary disease. This number increases in immunodeficient patients.
Pulmonary manifestations of TB include cough with scant sputum production, hemoptysis, dyspnea, and pleuritic chest pain.
Extrapulmonary tuberculosis signs and symptoms include painless lymphadenopathy, known as scrofula, which is the most common extrapulmonary manifestation.
Patients can have pericarditis, meningitis, arthritis, epididymitis, orchitis, and prostatitis, as well as adrenal insufficiency. Think of tuberculosis in the patient with TB risk factors who presents with undifferentiated hypotension.
Tuberculosis can also cause osteomyelitis, which is called Pott's disease. It has a high affinity for the thoracic spine. All patients with signs and symptoms of tuberculosis, a positive PPD or quantiferin gold test deserve a chest X-ray in the emergency department. This is to help determine if it is a primary infection, latent infection, or reactivation of tuberculosis.
A primary infection can have infiltrates in any areas of the lung. However, they may have only hilar or mediastinal adenopathy.
Reactivation will have lesions in the upper lobes or the superior segment of the lower lobes. These can be cavitary or non-cavitary.
A latent infection can have a normal chest X-ray or show nodules and fibrotic lesions in the upper lobe. These are known as Gome complexes and are areas of scarring and calcification.
Be on the lookout for miliary TB on chest X-ray. It is so named for the lesions appearing like millet seeds. It is disseminated tuberculosis and is almost always seen solely in HIV patients.
Patients with a convincing story for active tuberculosis but a non-definitive chest X-ray should be admitted for PCR analysis of their sputum samples. 2 negative sputum samples are needed to definitively say that the patient does not have tuberculosis. These should be taken at least 8 hours apart and one should be an early morning sample.
Treatment for active TB is RIPE therapy. RIPE includes rifampin, isoniazid, also called INH, pyrazinamide, and ethambutol for 8 weeks, followed by continuation of only isoniazid and rifampin for 18 to 31 weeks.
All of these medications can have side effects. Rifampin can cause orange discoloration of bodily fluids. Isoniazid can cause hepatitis, peripheral neuropathy, and seizures. Pyridoxine, also known as vitamin B6, is the treatment for seizures caused by isoniazid.
Pyrazinamide causes hepatotoxicity and polyarthralgias. And ethambutol can cause retrobulbar neuritis, which can cause a red-green color blindness.
Treatment with isoniazid, rifampin, or isoniazid with rifapentine should be considered in patients with latent TB if they have had a recent conversion of their PPD, they have had close contact with someone with active TB, or they are immune compromised.
Patients can be discharged home if they are otherwise healthy. They also must be reliable to stay under home isolation and follow up for their medications and checkups.
TB is a reportable disease, and the health department should be contacted prior to the patient leaving the ED. Omit any patient who is ill-appearing, unreliable, or if the diagnosis is uncertain.
To summarize, know the difference between primary, latent, and reactivation of tuberculosis, as this may determine treatment and disposition of the patient with TB.
The pulmonary manifestations of TB are easy to remember. It is the extrapulmonary manifestations that may be missed.
Right therapy is indicated in patients with active TB. Know the side effects of each medication and warn your patients about them.
Tuberculosis is a reportable disease. You must contact the health department before the patient leaves the emergency department. So that's it for this case.
Send us your comments, suggestions, and cases to theclinicalcorrelation@gmail.com and follow me on Twitter @MDNotified.
And me at EMLLou. Thanks for listening.